Good afternoon, yes, sir. And dear madam and dear colleagues. I'm the Tark from Group 36. Today my presentation is about survey on prophylactic antibiotic use in elective surgical procedures at the tertiary care center. First, we will look into some facts about surgical site infections. Surgical site infection is one of the main complications in the patients undergoing surgeries. There are multiple strategies available for preventing these surgical site infections. Out of them, perioperative microbial prophylaxis is a widely used method. Now we consider what is a prophylactic antibiotic. Antibiotic prophylaxis is a process of administration of antibiotics prior to the initiation of surgical procedures to decrease the risk of post-operative infections. Antibiotic prophylaxis is recommended in some clean surgeries, such as vascular surgeries and some surgeries that use prosthetic materials, and all clean contaminated surgeries. This is the guideline that we use to evaluate correct choice, dose, timing, and duration of antibiotics. This is National Guideline on Empirical and Prophylactic Antibiotic of LANKA 2016. These are the objectives of our research. The main objective was to assess the use of prophylactic antibiotics in routine general surgical procedures at teaching hospital PERADENIYA. Under that, we assessed the indication and antibiotic dosing and right route, antibiotic timing and duration of antibiotic prophylaxis. In this study, we used prospective cross-sectional study with the descriptive component, and this was conducted in 4 general surgical wards and surgical theatre at teaching hospital PERADENIYA. The inclusion criteria were patients should more than 18 years old, and patients should not undergo any surgeries within past 3 months, and patients should not take antibiotics within past 3 months, and all should be clean and clean contaminated surgeries. The only exclusion criteria was immunocompromised patients. As the sample, we took a maximum number who were in study category according to inclusion and exclusion criteria, and we used convenience sampling, and custom-made questionnaire were used, and the data for questionnaire were obtained by being at the ward and theatre on the day of the surgery. This is the questionnaire that we used. And in the data analysis part, all collected data were entered to Microsoft Excel, and descriptive results were presented as percentages of total responses. Now let's go into our results. First of all, we categorized surgery as clean and clean contaminated surgeries according to NICE guideline UK 2009. In that, there were 51 clean surgeries and 29 clean contaminated surgeries. There were collectively 80 surgeries. In that 80 surgeries, prophylactic antibiotic was indicated to give in 55 surgeries, and in 25 surgeries, prophylactic antibiotic was not indicated to give. Now we consider the administration of prophylaxis according to our guideline. In the antibiotic prophylaxis recommended group, there were 55 surgeries, and it was given in 48 surgeries. And in 7 surgeries, antibiotic prophylaxis was not given, even though it is recommended to give. In antibiotic prophylaxis not recommended group, in 16 surgeries, antibiotic prophylaxis was not given. And in 9 surgeries, antibiotic prophylaxis was given, even though it's not recommended to give. Collectively, 80% of surgeries show compliance with the recommendation on administration. In some surgeries, combination of antibiotics recommended. As example, in cholecystectomy, cefuroxime and metronidazole both were uh, indicator to give. In that case, we considered each antibiotic separately. There were 47 instances of antibiotic administration of that. And we took some choices as inadequate when there are only one of the antibiotic given when recommended combination. There were correct choice in 27 surgeries, and 5 surgeries were in incorrect surgeries, and 16 surgeries were in inadequate choice category. When we consider dose, route timing, and indicated given category surgeries, the compliance with the route was 100%, and with the dose, that was 72.34%, and with timing, it was as low as 6.38% with the compliance with the guideline. Overall result of the study was full compliance to choice, dose, route, and timing was seen only in 2 surgeries out of these all 8 surgeries. It was low as 2.5%. And conclusion of our surgery was prophylactic antibiotics were used for the majority of prophylactic indicated surgeries, and high rate of non-compliance of timing greatly contributed to the extremely low total compliance. And improper use of prophylactic antibiotics can result in failure to achieve expected results in reduction of surgical site infections. And recommendations of our final recommendations of our study was to discuss the study findings with clinical teams such as teams and expand future studies on surgical prophylaxis to a longer duration, more surgeries and longer large sample size. These were our recommendations. And thank you.
To see your the results that you have received, some statistics indicated.
So we had limited time, and we considered all population as it, where we considered 4 general surgical wards, and we thought that it's not needed to use advanced statistics.
How to improve the what are the ways you could improve the study? What are the ways that you could improve the study if you have more time?
If there's more time, we will use larger large sample.
What part sample method can we improve on that?
As sampling method, we can use
Perspective observation.
yes. Single. We can use multiple centers if we have local digits. Yes. Yes. Sir.
This announcement is for the judges. You can access the abstract on the WhatsApp group for the judges. Next up, we would like to invite Udagampada IU, who will be delivering their presentations on knowledge, attitudes, practices, and factors related to antibiotic use during pregnancy among antenatal clinic attendees in KANDY, Sri Lanka. Good afternoon, Chairperson, judges, and my colleagues. I'm Umanga Udugampala, representing my research group to present our research on knowledge, attitudes, practices, and factors related to antibiotic use during pregnancy among antenatal clinic attendees in KANDY, Sri Lanka. So, as we know, infections during pregnancy can cause many negative outcomes in both mother and as well as the neonate. But using antibiotics to treat these infections improperly can have more worse consequences. Therefore, it is important to identify factors driving antibiotic misuse in pregnant women to implement effective interventions. So our objective was to describe the knowledge, attitudes, practices, and the associated factors regarding antibiotic use during pregnancy among pregnant women attending antenatal clinic of a tertiary care hospital in KANDY district. With this objective, we conducted a cross-sectional description study, and our expected minimum sample size was 352. We used convenient sampling method using a self-administered questionnaire. We collected data between June and July 2023 from pregnant women attending antenatal clinic of teaching hospital PERADENIYA. Before that, ethical clearance was obtained from the Institutional Ethics Review Committee, Faculty of Medicine, University of PERADENIYA. So the data collected in the printed questionnaire first transferred into an Excel spreadsheet. Then we analyzed the data using SPSS version 22. We use descriptive statistics to describe our population, and we also calculated the knowledge score, attitude score, and the practice score. These scores and also the individual items were compared across different groups. Let's see what we have found. So in our study group, majority of our participants were below 30 years of age, had higher education, and also were in the first trimester. As you can see here, most of our participants claim that they were aware about the term antibiotics, but they were not about the term antibiotic resistance. And main sources of information regarding antibiotics of our study population were medical officers and midwives. So when we consider the knowledge regarding antibiotic use during pregnancy, many of our participants thought antibiotic treatment is necessary for common cold and cough, which we know, of course, most of the time are viral, viral etiology. And interestingly, 42.6% of our participants misidentified paracetamol for Panadol, which is a commonly used analgesic, as an antibiotic or commonly used antibiotic. This misconception was also identified in a study conducted in general population in Sri Lanka as well. And our median knowledge score was 5 out of 70. 48.6% of our participants neither agreed nor disagreed whether pregnant women should never use antibiotics during pregnancy. But large majority of our participants agreed for a doctor's consultation prior to use of antibiotics during pregnancy. And median attitude score was 4 out of 6. Out of 383 participants, 126 participants acknowledged of using antibiotics during their current pregnancy, and majority was for common cold. We think that this malpractice was due to misconceptions in pregnant women regarding antibiotic effectiveness and also misconceptions and malpractices of prescribing doctors. Not completing the full course of antibiotics prescribed after symptoms getting improved was the main malpractice we identified in our study population. Median practice score was 6 out of 7. And we also analyzed some factors associated with knowledge, attitudes, and practices regarding antibiotic use. As you can see here, level of education, employment status, and monthly household income were significantly associated. There was significant difference of distribution of the knowledge score between the categories of these
descriptional factors. And also attitudes, distribution of attitude scores significantly different between the categories of age, level of education, and monthly household income. But there was no difference in distribution of practice score between the categories of any of the population characteristics that we analyzed. But there were factors associated with individual practices, such as monthly household income associated with the use of antibiotics without prescription from a doctor, and taking all the antibiotic doses as per the instruction given by the doctor, and also the employment status with use of antibiotics without prescription from a doctor, and completing the full course of antibiotics prescribed by the doctor even after his intervening. At the end of this study, we concluded that although the overall knowledge regarding antibiotic use during pregnancy was not satisfactory, pregnant women had good attitudes and practices toward antibiotic use during pregnancy. And we recommend conducting qualitative study to identify other socio-economic and socio-cultural factors causing antibiotic uses, and also including topics regarding antibiotic use and implications of antibiotic resistance during training curriculum of midwives. And we had some limitations during conducting this study, such as the study was based on one tertiary care center in KANDY district, which could lead to selection bias and thus reduce the generalizability of our results. These are acknowledgements and these are references which can be go through. Thank you.
May I ask one question about actually it's not a question, it's an observation and a statement. Regarding presenting the results the details, when we put up in better and the statistic along with the people. You have mentioned the test and but then you haven't given the statistic for each value. That was an observation.
How exactly did you take the questionnaire?
This is the questionnaire, and we conducted study many things, and we to the page before the thing started, and first we have given waiting for the start, and we gave the questionnaire and asked the people questions.
How do you think interview-based survey will come up with it?
We used quite a lengthy question. Many questions, and we there is a large contour for the listeners of the participants. And think that in a lengthy questionnaire also they have to answer them fast, and the result have not been good. But when they are in an interview-based study, we could take more qualitative results than quantitative results, which is more suitable in this kind of. Yes, we first made the question in English and then translated it into Tamil and Sinhala, which are most commonly used Indian languages. And we asked from our participants whether they are comfortable with Sinhala or Tamil, and we gave them preferable language question. Yes.
Question from the audience.
Thank you. Ladies and gentlemen, please welcome our next presenter, Ms. T.N. Hewage, to present their research on surveillance of urine samples received for culture and related urinary pathogens at a tertiary care hospital in Sri Lanka.
Good afternoon, everybody. I am Kandi Hewage, and today I am here to present my research presentation on the topic of surveillance of urine samples received for culture and related urinary pathogens at a tertiary care hospital in Sri Lanka. This is the outline of the today's presentation. So let's go through one by one. Let me give a brief introduction to the topic. Urinary tract infections are one of most common infections all over the world, and according to the available data, every woman has a 60% of lifetime risk to having bacterial cystitis, and also 13% of lifetime risk for men as well. Here are some literatures that I have used. Let me explain the significance of the study. Rather than the overseeing of epidemiology of the urinary pathogens, from this study mainly focused on the clinical impact of the clinical practices with the type of the urine samples. As examples, if it is mentioned the type of the sample in the request form, the laboratory processing methods are going to be different. And also the clinical interpretation can be misguided if the when reporting the positive culture outcomes such as in catheter-urides, and also collection time and the transportation conditions of the urine sample significantly affect on growth on lab processing and in the misgrowth and scanty pre-growths, and also sampling before starting the antibiotics therapy also affect significantly on the result of the test. These are the objectives. The general objective of this study is to evaluate the type and the quality of urine samples received from inward and clinic patients for culture, and impact of urine culture results on patients, and antimicrobial resistance in pathogens at tertiary care institute in Sri Lanka. Let me explain the materials and methodology. This is a descriptive cross-section study, and the study setting is microbiology laboratory at teaching hospital PERADENIYA. Minimum pre-rated sample size is 96, and all urine cultures from inward and clinic patients which received for routine culture and the ABST taken as the sample study population and excluding the OPD samples. And all consecutive samples which received for culture were taken as sample. Let me explain the methodology. There are 3 stages. First stage is data collection for evaluating as 4 components. First one is container evaluation. Container was evaluated under these 5 criteria, and also request form is evaluated according to the content, including the demographic data, date and time of the sample, and type of the sample, and also patient DHT verified, and patient details also gathered with the interviews and all the patient culture outcomes and ADST results were considered. Second step is the confirmation of the identification of isolated pathogens via the biochemical testing. And the next last step is the ADST resistant mechanism performed. Let's go through the results of evaluated 648 containers. Only 12 containers not properly labeled. As a percentage, it's 1.1%. Of evaluated 1,008 request forms, 153 request forms not included the required demographic data. As the percentage is 15.18%, and only 32 request forms including the time and the date of the sample collection, and also majority of the request forms did not specify the type of samples, whether it is clean catch or catheter-urine or other type of samples. It is significant impact, and out of those 369 evaluations revealed 99 samples supposed to be catheter-urine, but it was not mentioned in the request forms. And also, out of 250 cluster evaluated, only 95 urine samples were obtained before taking the antibiotics. As a percentage, it's 39%. And out of 117 patients, 48 patients has shown as no culture outcomes. And also, out of 189 pure and the predominant growth culture outcomes, Escherichia coli has the highest isolation rate among the patients. And also, out of 14 membrane resistant isolates, only 28.57% were serine carbonamide producers, and the others were metallo-beta-lactamase producers. As the discussion, urine samples must be plated within the 2 hours of the collection. Otherwise, it leads to increase the possibility of multiplying the organisms, and it will come up as the false positive results. And also, as a conclusion, with the results, urine culture test facility is suboptimally utilized as clinical application and interpretation of catheter and clean catch urine culture results. Further evaluations are needed to improve awareness of collecting urine samples before starting antibiotics, and proper labeling of time and type of the urine sample, and to minimize the delays in collecting and the transporting to the laboratory. Thank you.
Okay.
Sorry, it's a surveillance. Yes.
Actually, we need to say that we have some sort of tool to assess whether that is being done properly. It's a tool.
I will not use the questionnaire.
How do you check? Is it do you use the questionnaire or?
And I interviewed the patient or the bystander sometimes.
How do you check the is there a way to generate a audit form based on something that the person can use? Can you give it to tool out of that?
I don't have that kind of idea, but
Others also to understand how this should work. I think we will agree on this. So we can understand that, right? Okay. And make it user-friendly by what it is.
Sorry?
Make it user-friendly by what it is.
Yes.
At the time of receiving the sample, the audit tool can place in the create the boxes. And how do you complete the audit after you say somebody creates the app, then you have instructions to the people to make some changes and after that you complete the cycle by waiting 6 months. So that is the direction is to make. So it's already designed by the other just
Yeah, I collected the request from the laboratory. Then I went to the wards and searching for patients. After interviewed, I got the details. And also we got the PhDs as well, whether there are any legal symptoms.
So you were going to find out the time gap between sample collection and in the lab, and then finally, so you are going to do that or not?
Time gap means that sample collection
and then take.
Before coming to the laboratory means. Yes, I didn't assess it. I mean that I couldn't evaluate it statistically, but several observations. But it's not. Yeah.
Any questions on that? We move on to this.
Our next presenter, Ms. IPS Soumya, will now present a research on evaluating knowledge and practices of preventing catheter-associated urinary tract infections among doctors in teaching hospital PERADENIYA and medical students in University of PERADENIYA.
Good afternoon, everyone. I am Santhi Samna, representing my research group. We conducted our research on evaluating knowledge and practices of preventing catheter-associated urinary tract infections among doctors in teaching hospital PERADENIYA and medical students in University of PERADENIYA. Urinary tract infections are the fifth most common type of healthcare-associated infections reported in National Healthcare Safety Network in USA. Among UTIs that are employed in the hospital, approximately 75% of them are associated with a catheter. Catheter-associated urinary tract infections are a major health concern due to complications and frequent recurrence and related to high economic burden and morbidity. Our general objective was to assess knowledge and practices related to prevention of catheter-associated UTI among doctors in teaching hospital PERADENIYA and to assess the knowledge related to the prevention of catheter-associated UTI among medical students in the batch 16-17, 17-18 and 18-19 in University of PERADENIYA. Ethical clearance certificate was obtained from Ethics Review Committee and permission granted to gather data from doctors from Director of Teaching Hospital PERADENIYA. Paper-based questionnaire for all of directors and Google Form-based questionnaire for medical students of respective batches were given. The data was collected using self-administered questionnaire in English from June to August 2023. The response database was created in Microsoft Excel and analyzed using statistical software package Timecodes. Contingency tables were used to characterize the participants' demographic details. Mean, standard deviation, and range were used to describe the continuous variables. Independent sample t-tests were used to compare knowledge and practices across sex, while one-way ANOVA and post-hoc tests were used to compare across designation and years of experience. Pearson correlation was used to assess the correlation between knowledge and practices of preventing CAUTI. Independent variables of our study were years of experience or the individual academic year, sex, and designation, while knowledge of prevention of catheter-associated UTI and practices of prevention of CAUTI were the dependent variables. In our study, the following are the inclusion criteria. All the doctors of selected units, including medical, surgical, pediatric, gynecology and obstetrics, orthopedic wards, nephrology and dialysis unit, and ICU, and also third year, fourth year, and final year medical students. All the doctors reported to other units other than the selected wards, and medical students other than the selected years were the exclusion criteria. In the demographics of the medical students, the 18-19 and 17-18 batch has more female participants. The majority of the participants were from 18-19 batch. In the demographic of the doctors, there was more male participants, and most of the participants were having more than 10 years of experience. According to the designation, 50% of the participants were senior house officers and medical officers. In the results of the knowledge of preventing catheter-associated UTI, 18-19 batch and 17-18 batch has highest mean knowledge and also from their male participants and also for the doctors. But there was no significant association between the sex and the knowledge of preventing catheter-associated UTI. Also, based on the academic year, 17-18 batch has the highest mean knowledge. For the doctors, based on the designation, consultants, senior registrars and registrars has highest mean knowledge, and also the doctors who is having more than 10 years of experience. There was a statistically significant correlation, association between the designation and the knowledge, and also the years of experience and the knowledge with this 0.004 and 0.002 p-values. In the results of the practices of preventing catheter-associated urinary tract infections, male participants has highest mean knowledge, highest mean practice. Based on the designation, a senior house officers and medical officers has highest mean practice, and the doctors who is having more than 10 years of experience. In summary, we assess only the knowledge of preventing catheter-associated UTI among medical students, and there was no statistically significant association between the sex or the academic year and the knowledge of the preventing catheter-associated UTI. In the doctors, we assess both knowledge and the practices of preventing catheter-associated UTI, and there was a statistically significant difference between association between the years of experience or the designation and the knowledge of the preventing catheter-associated UTI as well as for the practices. But there was no statistically significant association between the sex and the knowledge or the practices of preventing catheter-associated UTI. Also, we assess the correlation between the knowledge and practices of preventing catheter-associated UTI. There was no statistically significant correlation between the knowledge and practices of preventing catheter-associated UTI with the Pearson correlation coefficient of 0.084. In our research study, we would like to highlight that gender does not significantly impact on both knowledge and practices among doctors as well as medical students. Doctors with more experience tend to have higher levels of knowledge and better practices regarding catheter-associated UTI prevention. Lack of a significant correlation between the knowledge and the practices force highlights the potential gap between what doctors know and what they actually do in their practices. And also, we would like to highlight that having a good knowledge doesn't mean that they have a good practice. In conclusion, our study emphasizes the importance of initial introduction of infection prevention and control concepts and continuous re-education together with clinical exposure for medical students to gain and register knowledge about prevention of CAUTI. It also emphasizes the importance of ongoing education and training, particularly for the less experienced doctors. This also highlights the need for targeted interventions based on the years of experience and designation of doctors. These are the things what we have came up with our research. The knowledge regarding catheter-associated UTI among medical students and doctors has a room for improvement. So, online free course for intern studies can be conducted. To improve the practices of doctors, regular workshops can be conducted. Frequent quizzes, competitions or debates can be conducted to strengthen their knowledge regarding CAUTI. And also attractive paper posters or brief video clips on LCD panels can be displayed to make some more basic concepts familiar. These are our references, and I would like to thank all the participants who participated in our study, and also Director Teaching Hospital Peradeniya. Our dean was Professor Vasanthi Pinto from Faculty of Medicine, University of Peradeniya, and Department of Community Medicine and Microbiology from the Faculty of Medicine, University of Peradeniya. Thank you.
Start the question.
One thing is sound, right? It's LANKA. Why did you choose two populations for one study? What's the reason?
Thank you for the question, Manu. I would like to direct that question to Priyanka, our research member Priyanka.
Anybody from the research team? Why did you choose two different populations for one study?
Thank you for the question, ma'am. Actually, we chose two different populations because, we wanted to know how well our medical students are also gaining, because they have recently completed their infection module regarding the infection module. So we wanted to see how well they have incorporated that knowledge and how well they have registered that knowledge. And then we could not put both the population into one group because one of the group have already completed their course and then they have years of experience as well, or they are having much hand-on practices. Whereas the other group, they did not have much hand-on practices, because of which we could not include them in one group, so we decided to do it on two.
Thank you, but I don't agree with you. I mean, if you are not comparing the two populations, you should not put two populations into one study. Then there should be some link between the two populations. There are two different studies in one, doesn't mean as one study. That is one view, just for learning purposes I am showing you. Then the next one, when you gave me this eligibility criteria, why did you just select some of the names? Was there, the doctors?
Thank you for the question, madam. Actually, we selected specific units where the catheters are frequently used, and we remove other units because we didn't use the catheters recently. And that's it. Thank you.
So, we have something about the capital insertion part. So, we start this infection control. Usually, the infection control, the nursing staff is primarily responsible. So, most of the interventions in the day weeks in the world, they are monitored by the nursing staff. And they have a capital insertion part. How would you improve your study to create something like that in the Sri Lankan setting? Done some observations. First, to generate a capital insertion value, that is an instruction sheet or a checklist. And for the capital insertion to be done, under the supervision of the nursing officer or a medical officer. So one person visits, the other person observes it and reports it. How would you implement that sort of thing in your setting? Would you be able to do it? Would you be able to implement such a strategy?
In our questionnaire, we question about the catheterization model and catheter maintenance model, and we use all the questions in the catheterization and maintenance model as well. So with that, we can make a
what I would like to teach the audience also the students. So when you are going to evaluate or assess the practice, it is probably better evaluated of real time. Either a video and doing observation, and proxy. So probably what I would suggest is if you are going to enhance or improve your study, have a real-time observation and studies in the time of evaluating the practices of the group of individuals in the last day and then check what they do. So this is something to think about, right? Anything else?
Thank you. Our final presenter for this session is Mr. S.C. Manavagage, who will be delivering their presentation on knowledge, attitudes, and practices on rational antibiotic use among a selected sample of undergraduates at the University of PERADENIYA.
Good afternoon, everyone. Good afternoon, judges and everyone in the audience. I'm Sandhurwan Manavagage. On behalf of my group, I would like to present our research titled Knowledge, Attitudes and Practices on Rational Antibiotic Use among the selected sample of undergraduates in the University of PERADENIYA. First, we chose this research as antibiotic resistance is a major problem worldwide. According to the WHO report, we can see that 1.27 million global deaths occur due to this antibiotic resistance, and more than $1 trillion is costed due to antibiotic resistance. So, in our objective, we assess the knowledge, attitudes, and practices on rational use of antibiotics among undergraduates at the University of PERADENIYA. Also, we describe the factors that are influencing this antibiotic resistance. In our methodology, we used a descriptive cross-sectional study. First, we used a multi-stage sampling where we took all 9 faculties and then divided into health-related and non-health-related faculties. In that, we used a lottery-based method to choose 2 faculties from each category. From the health-related faculty of medicine and faculty of allied health sciences were chosen by, from the non-health-related faculties, faculty of science and faculty of engineering was chosen. Using the Cochrane's formula, the sample size we calculated was 300 microparticles. We used this simple random sampling and we chose the 18-19 batch to remove any confounding factors. And then we created a self-administered question. First, we pre-tested it on 1920 batch to ensure its quality, and we also translated into Sinhala and Tamil languages, then back translated into English to ensure its quality. In the self-administered questionnaire, socio-demographic data, knowledge, attitudes, practices regarding rational use of antibiotics were measured. We got 393 participants. We analyzed this data using the GEMOMI. We analyzed the socio-demographic data and each statement of knowledge, attitudes, and practices of rational use of antibiotics using descriptive data. And to see the factors that are affecting it, we use the chi-square or the Fisher exact test chemistry in essay. We use the level of significance as less than 0.05. The results were divided according to the demographic characteristics, the knowledge, attitudes, and the practices regarding rational use of antibiotics. In the demographic characteristics, we got nearly equal population of males and females, and also nearly equal amounts of health-related and non-health-related faculty participants. This is our assessment regarding the knowledge of rational use of antibiotics. Here you can, in the green colored boxes, you can see that the majority have given the correct answers, while in the red boxes you can see that majority have given the wrong answers. Here we can see that in most aspects, the undergraduates have given correct answers. So the knowledge regarding antibiotics was satisfactory in most aspects, while in some aspects we could see their knowledge were poor. In the association, there was significant association in some aspects with regard to sex and the faculty, while females and health-related faculties having more knowledge on their counterparts. And in the attitudes, we could also see that in many aspects correct attitudes were given, while in some aspects wrong attitudes were given by the participants. It is based mostly on suggestions, giving antibiotics based on suggestion of someone. In the association, we could see that most of the participants had significant association in sex and faculties, with females and health-related faculties having better attitudes than its counterparts. Despite having good knowledge and attitudes, we could see that there were poor practices among the participants based on their over-the-counter usage, storing antibiotics, and sharing antibiotics. We could not see any association in sex, but there were some association in the faculty. Their health-related faculty had better practices than in non-health-related. In conclusion, we could see that undergraduates had better knowledge on rational use of antibiotics, but in some aspects they lacked knowledge. But overall attitudes of undergraduates were satisfactory in most aspects, but there were poor practices among undergraduates even though the knowledge and the attitudes were good. Also, the undergraduates from the health-related faculties had better knowledge, attitudes as well as practices than the non-health-related faculties. But even among the undergraduates from health-related faculties, certain aspects of the knowledge, attitudes and practices were lacking. So, in our limited study, we recommend to bridge these gaps in knowledge. But we can do this by, when doing antibiotics resistant workshop, we should emphasize more about common symptoms where self-medication is done and why it is important to consult a physician over self-medication. Also, we could promote a tailored behavioral change communication to address these gaps in practices in spite of having good knowledge and practice, knowledge and attitudes. Also, more stricter guidelines and policies should be established in order to promote correct practices in antibiotics usage. If we are to recommend further research, we could incorporate an interviewer-based questions for coupled with focus groups in order to understand why poor practices are there in spite of having good knowledge and attitude. So these are our references, and we would like to acknowledge all the participants who took part in this research and the Vice Chancellor of the University of PERADENIYA and Deans of Faculty of Medicine, Faculty of Health Sciences, Faculty of Engineering, Faculty of Science for giving us this opportunity. Thank you. We use we used previous studies that had done this kind of research. There were many type of research in different countries, and we adapted that into our culture. As we could not validate this questionnaire, so we chose each statement separately. We discussed each statement separately. That's
kind of find out the legal effect of prescribing antibiotics. This is a question for Dr. You answer. I believe that there are couple of health care system agencies, antibiotics are taken over the counter and to prescribe proper pharmacists to prescribe antibiotics. And even the health student can't go to the counter and even doctor can't go to the counter and study. That is a really problem. Is there a way to sort of assist the actual malpractices? That's a legal thing to do. Would you extend the study to demonstrate that there is indeed something illegal happening? How it is?
we could do some interview-based discussions with some of the undergraduates, so the participants who had poor practice or who used over-the-counter medication to see how they obtained it and why they are going to do it without going for a doctor. So that could be
Any other question?
Thank you.
We kindly request the speaker to please remain on stage to receive the certificate from our judges. We cordially invite Dr. Manjula Perez to award the certificate.
Now we cordially invite Dr. Desha Mehera to present the rest of the certificates. And that concludes the first session of oral presentations.
Thank you, Honorable ladies and gentlemen, Honorable judges. I would like to call upon the conference chairperson, Dr. Samidina Ratna, to hand over certificates of appreciation to Honorable judges, Dr. Manjula Perez and Dr. Desha Mehera.
Ladies and gentlemen, next up, we would like to announce that lunch will be served at the pillared area for all those with food tokens, the senior common room for all special guests and staff, and the remaining audience can proceed to the anterior canteen where lunch can be purchased. Following lunch, we will have the panel or presentations session. The poster presentation judging will take place during the lunch hour at the community medicine tutorial room. And that concludes the first session of all presentations for PEMSAR 24. We would like to extend our gratitude to our chairperson and judge for overseeing an excellent session. Following lunch, we will begin our second panel session of oral presentations. Please take note that the oral presentation scheduled for parallel session 2A will be held at the Physiology Lecture Theatre. Parallel session 2B will be hosted at the East Lecture Theatre. And the parallel session 2C will be held at the West Lecture Theatre. You can refer to the session schedule to find out which topics interest you and go to the appropriate venue. Thank you.